Hello, welcome to week 3. This is the content session for NU 621 Advanced Pathophysiology. My name is Dr. Christy Burks. We're going to get started. I do want to remind everyone whenever you're doing the reading, make sure that you're looking and paying close attention to learning or understanding the clinical manifestations, the pathophysiology characteristics, along with the associated labs and diagnostic tests for each of these disease processes. Okay. All right. We are going to start with SIADH, which is the syndrome of inappropriate antidiuretic hormone secretion. This results in enhanced renal water retention, increased or that excessive release of antidiuretic hormone, the ADH, from the posterior pituitary gland in the absence of that normal physiological stimuli for its release. So the ADH promotes water reabsorption in the kidneys. It leads to that dilutional hyponatremia. And with hyponatremia, the serum has a lower osmolality than the brain cells. Pardon me. The osmotic imbalance causes the water to shift from the extracellular fluid into the brain cells, resulting in that cellular edema or swelling. So, severe brain edema can increase intracranial pressure and potentially cause the herniation, seizures, coma, and even permanent brain damage if it's not properly treated. Now, the main pathophysiological mechanism of hyponatremia in SIADH is that excessive water reabsorption by the kidneys. So that's what leads to that dilutional hyponatremia. In that SIDH, there is that inappropriate and continued release of that ADH despite that normal or increased plasma osmolality. So the kidneys, this causes the kidneys to help like reabsorb more water, resulting in that excess water compared to sodium in the body. So the dilution of sodium by the retained water leads to that decreased serum sodium concentration or the hyponatremia. So another way of thinking about this is when you're thinking about SIADH, compare it to like a leaky faucet in the sink. So the faucet, which I have an image here that kind of represents what I'm going to visualize here, so that way you can help visualize. So if you compare it to a leaky faucet in the sink, the faucet represents the body's ability to regulate the water balance. So in a healthy patient, when you need more fluid or water in your body naturally increases the flow through a faucet, releasing more ADH to retain that water, but there is an automatic shutoff when enough water has been collected to help prevent any type of overflow. With our SIADH patients, the faucet's automatic shutoff valve is basically stuck on. Therefore, when you have enough water or fluid, the faucet continues to leak, causing the body to retain too much fluid. And that's when we see the body's tissue gets overwhelmed with extra water, causing dilution of that serum body or blood sodium levels. So, similar to this leaky faucet flooding the floor here in this image. In SIADH, the body continues to keep secreting that ADH, even when the body does not need it, and it causes that fluid retention or hyponatremia. Now, some common causes include tumors, ectopic production of ADH, like that small cell carcinoma, especially like the stomach and pancreas. Even bladder or prostate cancer tumors can cause this. Other causes include pulmonary conditions like pneumonia, TB, asthma, cystic fibrosis, respiratory failure, where the requirement of mechanical ventilation is included, CNS conditions like encephalitis, meningitis, intracranial hemorrhage, even trauma. Surgery can increase ADH for about 5 to 7 days, so that's important to watch out for. There are some medications, especially in our older population or our elderly population. So if you think about some of the hypoglycemic, there's some antidepressant, narcotics, even antipsychotic drugs, or some of them, general anesthetics, and even our chemo agents and even NSAIDs can lead to this sometimes. So that is something to think about and consider. Now, our clinical manifestations, we talked about the hypotonic hyponatremia, hypervolemia, which is that fluid overload or weight gain. And then they also have that thirst or that anorexia, fatigue, dyspnea on exertion, and impaired taste. Now, when we think about our sodium levels, typically that like the sodium levels that drop rapidly from 140 to 130, we see different symptoms. So like from 130 to 120, we start to see GI symptoms like vomiting and abdominal cramps. And sodium levels 110 to 115, that's when it can lead to confusion, lethargy, even irreversible neurological damage. So symptoms can resolve with that correction of hyponatremia, but it is something that you have to do gradually and very carefully. Now, when we are talking about treatment, correction of the underlying cause and fluid restriction is one of the main things that we look at. So, with those severe cases, careful correction of that hyponatremia with that hypertonic saline and even a fluid restriction. And usually it's around or approximately 800 to 1,000 mLs a day, um, just depending on the provider and depending on the location, I'm sure. If corrected too quickly, there's a risk of neurological syndrome called central or CPM. So, vasopressin receptor antagonists or VRAs or Vaptins work by increasing the amount of solute free water the kidneys can excrete. So, this tends to correct it quickly without that fluid restriction. And it's used in our non severe hyponatremia patients sometimes. So, now let's look really quick just about or compare the two, the hyponatremia versus hypernatremia. Now we talked about hyponatremia, which is that electrolyte imbalance where the serum sodium level is below that normal range, which our normal range we know is 135 to 145. This occurs due to that relative excess of water compared to the sodium in the body fluids. So this causes the sodium concentration, the extracellular fluid to become that dilution or diluted. The main causes that we talked about and even additional causes are excessive water intake, sodium loss from conditions like vomiting or diuretic use, or impaired water excretion due to conditions like the one that we've been talking about, the SIADH. Other symptoms range from like mild nausea, headache to severe confusion, seizures, coma, and in extreme cases, we see that coma. Treatment includes restricting that water intake, replacing sodium losses, and addressing, again, the underlying cause. Now, there are a couple different kinds that hyponatremia that we look at. We look at hypovolemic hyponatremia, which is that loss of total body fluid that involves a greater loss of body sodium. Isovolemic hyponatremia, which is the loss of sodium without a significant loss of water, so that pure sodium deficit. Versus inadequate intake of dietary sodium. This is very rare because but it is possible in individuals that consume low sodium diets, particularly when diuretics are also being used as well. But if you think about some areas, so for example, United States, we look at all of the processed foods, look at the sodium. We encourage our patients to look at the sodium levels, and typically we can get our minimum sodium intake for the day in one meal if we're eating processed foods or canned foods. So just considering that. So this, like I said, this is rare, but it can happen. The other is dilution hypotonic hyponatremia, which is water intoxication. And this occurs when there is an intake of large amounts of electrolyte free water or replacement of fluid loss with like IV D5 in water, which dilutes sodium. So the glucose is metabolized to carbon dioxide in water, leaving a hypotonic solution with a diluting effect. And this excessive sweating stimulates that thirst and intake of the large amounts of electrolyte free water. So this can occur in endurance athletes. Some individuals with psychogenic disorders develop water intoxication from compulsive drinking of water. Others can cause, or other causes can include like tap water enemas, aspiration of free water from a non-fatal drowning. So that's something to think about if you have patients that this happens in. And then the use of SSRIs and of course SIADH. Hypervolemic hyponatremia, which occurs when the total body sodium amount is increased and there is an excess of water. So this increased sodium leads to an increase in ECF volume and the serum sodium concentration is decreased. So this can cause or causes include like heart failure patients, our cirrhosis of the liver patients, nephrotic syndrome. Edema typically is present in these cases. The last one is hypertonic hyponatremia, and this develops when the shift of water from the ICF to the ECF. So, as this occurs with hyperglycemia, hyperlipidemia, and hyperproteinemia, the osmotic fluid shift to the ECF in turn dilutes the concentration of sodium and other electrolytes. All right, versus our hypernatremia. So this is an elevated serum sodium level above 145. It leads to fluid shifting out of the cells, causing cellular dehydration and that shrinkage. So causes include excessive fluid losses, inadequate water intake, diabetes insipidus, and even kidney disorders. So your symptoms include thirst, lethargy, and muscle weakness or twitching. Treatment focuses on replacing that fluid deficit with hypotonic fluids and managing the underlying cause. So, both electrolyte imbalances require that close monitoring, and it's very important to do so to help prevent those complications. Sorry, this is just your lab values there. All right. Next, we're going to go into diabetes insipidus. This is a condition characterized by excessive urination or polyuria and increased thirst, that polydipsia, due to problems with fluid regulation. And there's two different types that we're going to just look at. And we've got central diabetes insipidus, which is caused by deficiency of that antidiuretic hormone, so that ADH or vasopressin produced by the hypothalamus or pituitary gland. Now, this leads to an inability to concentrate urine and conserve water. Next is nephrogenic diabetes insipidus, which occurs when the kidneys are resistant or insensitive to the ADH, despite normal or elevated levels of the hormone. The kidneys cannot respond properly to reabsorb the water, and this results in excessive water loss. Now, those symptoms that you see with these patients include that polyuria, which is that excessive urination, that polydipsia, which is excessive thirst, and nocturia, where they have the excessive urination at night. These patients also may experience dehydration, fatigue, and electrolyte imbalances if that fluid intake is inadequate. Now, both types can lead to dehydration, electrolyte imbalances, and high serum osmolality if not treated with desmopressin for that central diabetes insipidus or fluid replacement. So, with proper diagnosis through tests like the water deprivation test, which is very crucial to determine that underlying cause. Now, real quick, that water deprivation test with desmopressin, it's a desmopressin challenge. It's a key diagnostic tool which differentiates between the two forms of diabetes insipidus. So we have the lack of increase in urine osmolality after administration of the desmopressin or that synthetic ADH during a water deprivation test is indicative of nephrogenic diabetes insipidus, whereas in central diabetes insipidus, where the desmopressin would increase urine concentration by compensating for the ADH deficiency. So that is very important to know. Next, we're going to look at the pancreas. So the pancreas is both an endocrine gland that produces hormones, which regulates carbohydrates, fats, and proteins, protein metabolism, and an exocrine gland that produces digestive enzymes. Now, I know we learned about this in other pathophysiology classes. I just wanted to go over this a little bit more because it's important to understand and just kind of review this before moving on to some of the disease processes that we're going to look at. Now, the pancreas is where the islets of the Langerhans is located, and it contains the endocrine cells or the hormone secreting producing cells. There are four different types of these cells located here. We've got the alpha, the beta, the delta, and even the F, or it used to be called the pancreatic polypeptide or the PP, and even formerly before that called the gamma cells. So now we just call it the F cells. So the alpha cells, which secrete, synthesize, and glucagon to help increase glucose levels in the blood. That function of the alpha cells is to prevent blood sugar from dropping dangerously low, where we see that hypoglycemia. To do so, the liver is triggered to break down that glycogen into glucose and to release it into circulation. So, if the glycogen raises the blood sugar, insulin lowers glucose, both helping to create that nice balance. In conditions with that we see with like type 2 diabetes, the pancreatic alpha cells become less responsive to inhibitory effects of that glucose. So this leads to that increased unregulated secretion of glucagon from the alpha cells, even in the presence of high blood sugar or blood glucose levels. Glucagon acts to raise that blood glucose by stimulating glycogen olysis, breaking down that of the glycogen to glucose in the liver, as well as the production of new glucose from the amino acids and the other precursors. Now, the abnormally high glucagon levels work against the actions of insulin. So this further exacerbates the hyperglycemic state, and that's a characteristic of the type 2 diabetes. So the increased glycogen secretion contributes significantly to that elevated blood glucose levels when we see or talk about this condition. Versus we have the beta cells, which help synthesize insulin and secrete insulin and amylin. And the beta cells, it's the body's primary source of insulin. So the function is to maintain healthy blood sugars in the body. So the beta cells secrete the insulin, which helps absorb glucose from the bloodstream, which lowers the blood sugar, for example, after meals. Now, the beta cells are damaged in type 2 diabetes, where in type 1 diabetes, they are destroyed. So, for example, the body's immune system destroys the beta cells by mistake, and that is leaving the body unable to produce insulin or enough insulin, which leads to that hyperglycemia. Now, amylin is secreted with the insulin from the beta cells to work with the insulin, typically due to eating a meal or elevated blood glucose. Amylin is what signals the brain to feel that you are full, and this helps regulate food intake and regulate your appetite. So this action slows gastric emptying, regulating the glucose that makes it into the bloodstream. Now, delta cells, which secrete that gastrin and somatostatin, works by inhibiting the release of both insulin and glucagon from the beta and alpha cells. So this helps reduce rapid increases and decreases in sugar concentration. And lastly, the F cells, which again secrete the pancreatic polypeptide or PP that stimulates the gastric and antagonizes the cholecystine, cystokine. I'll get it out. This mostly happens after eating. So this helps balance that digestion by inhibiting gastric emptying and gallbladder concentration or contraction. That way, the pancreatic enzyme secretion occurs and signals the full signal to the brain. This helps control appetite. And again, they are a very important part of regulating that glucose level because of the appropriate secretion of insulin. Now, the textbook has a wonderful visual, which is figure 21.15, and it shows the pancreas and the cells and the different types of cells. Now, next, we're going to look briefly at diabetes. And according to the NIH, more than 133 million Americans have diabetes or prediabetes, so that approximately about 90 to 95% of diabetes cases are type 2. Diabetes mellitus is a group of metabolic disease characterized by hyperglycemia resulting from deficits in insulin secretion, insulin action, or both. Now, there's four different categories of diabetes mellitus. We have type 1, which we know is the beta cell destruction resulting in insulin deficiency. They're prone to ketoacidosis with little or no insulin secretion, and they become insulin dependent. And typically, these patients are not obese, typically. Now, type 2 is another, and type 2 is progressive loss of that beta cell beta cell insulin secretion frequency on the background of insulin resistance. There are other specific types like genetic deficits of beta cell function, genetic deficits in insulin action, and even disease of the exocrine pancreas, infections, and there's others listed in the textbook as well that can cause or lead to type 2 diabetes as well. Gestational diabetes, any degree of glucose intolerance with the onset or first recognition during pregnancy. The common underlying cause of gestational diabetes is insulin resistance combined with an inability of the pancreatic beta cells to compensate by increasing that insulin production sufficiently. So during pregnancy, hormones from the placenta like estrogen, cortisol, and even human placental lactogen induce that insulin resistance in the mother. Normally, the pancreatic beta cells can increase insulin secretion to help overcome this resistance. However, in gestational diabetes, the beta cells cannot keep up with the increased insulin demands, and that leads to the impaired glucose tolerance and hyperglycemia. Now, this beta cell dysfunction or inadequate compensatory insulin response on a background of pregnancy-induced insulin resistance is the primary pathophysiology behind most of the cases of gestational diabetes mellitus. So, all right. Next we have, sorry, I forgot to click that one. Ooh. Trying to get it. There we go. All right, let's go. Just looking to see if there's anything else I want to mention. This, so I do want to mention too, if we leave untreated, like the type 1 diabetes, we leave that untreated, the lack of insulin can lead to that severe hyperglycemia. Now, this is where the kidneys attempt to remove the excess glucose through increased urination. So we start to see that polyuria. However, this causes excessive fluid loss, leading to dehydration. And additionally, the high blood glucose levels trigger an osmotic diuresis. So, where more water is pulled from the body into the urine to dilute the high glucose concentrations. Now, this further exacerbates the dehydration. So, the combination of polyuria from hyperglycemia and the osmotic diuresis results in that significant fluid volume depletion and electrolyte imbalances, causing the patient to become very dehydrated. So, this is where we see that in the setting of insulin deficiency, like in our type 1 diabetes patients, lipolysis and ketogenesis contribute to that development of diabetic ketoacidosis or DKA. Now, lipolysis is the breakdown of that stored fat or the triglycerides into the free fatty acids and glycerol. Without the insulin, lipolysis is enhanced, and that leads to increased delivery of that free fatty acids to the liver. And in the liver, these free fatty acids undergo that ketogenesis, which is the production of ketone bodies through fatty acid oxidation. So the accumulation of ketone bodies causes the metabolic acidosis in that hallmark of that DKA. Ketogenesis serves as an alternative energy pathway when there's a lack of insulin and glucose that cannot be utilized efficiently by these cells. Now, in the Pathophysiology Made Incredibly Visual book that you have access to as that, one of those 3Ps resources that I showed you last week, or I think it might have been in week 1 or the preview, but anyway, you go to the library to get to that. So you might have to refer back to that, but I've got it on there. you have access to these additional. This image shows and discusses the normal body cell versus the diabetic body cell. So showing that closed glucose portal, it shows the difficulty that glucose has trying to enter the cell, and that depriving the cells of the energy. The lack of the energy causes the glucose to bind up in the blood vessels, which damages all the body organs. The other thing I want to mention is talking about type 2 diabetes. So we know that there are some things that are associated with type 2 diabetes, one in particular, dyslipidemia, which is characterized by that increased levels of low density lipoprotein or LDL cholesterol, and a decreased level of high density lipoprotein, which is that HDL cholesterol. LDL carries cholesterol to tissues, and high levels promote atherosclerotic plaque formation in the arteries, whereas HDL removes cholesterol from the tissue and transports it to the liver for excretion, providing a protective effect. So the combination of elevated LDL and a low HDL in type 2 diabetes accelerates the development of the atherosclerosis, and that's what increases the risk of that cardiovascular diseases like coronary artery disease and even stroke in our patients that have that type 2 diabetes. And we see that insulin resistance, the hyperglycemia. This also contributes to the endothelial dysfunction and inflammation, and that further exacerbates the atherosclerosis progression. We also see that diabetes is associated with impaired immunity and that decreased wound healing ability. So that contributes to that non-healing foot ulcers, for example. Hyperglycemia impairs the leukocyte function, and that reduces the body's ability to fight infection at the wound site. This also causes like a dysregulation of collagen synthesis and decreased angiogenesis, and that slows the formation of new blood vessels needed for that wound repair. Additionally, that neuropathy and diabetes reduces that sensation, and that increases the risk of unnoticed injuries that can lead to that ulceration or wound formation. So, the combination of impaired immunity, poor healing, and neuropathy makes diabetic foot ulcers difficult to resolve without proper management of blood glucose levels and wound care, and even those foot checks. So, making sure that our patients know to check their feet, and even at appointments, making sure that someone is doing those checks as well. All right, I think that is all we're going to cover on that one. The textbook does have a great table. It's 22.6. You might look at it, which reviews the classification and characteristics of diabetes mellitus as well. So that's a great thing to look at. Next, we're going to talk about obesity. Now, the CDC offers many statistics, some that include more than 2 in 5 adults have obesity. Additionally, those adults with obesity have other serious chronic diseases like diabetes, heart disease, and so on. So that is something to think about. Now, the next image here is an image of adult obesity prevalence map for the US. And this is, I think, 2023. So I thought this was an interesting statistics when you look at the United States. Now, the pathophysiology of obesity involves several different components of genetic, environmental, and neuroendocrine factors that can lead to the imbalance between that energy intake and expenditure. So, central to this is the dysfunction of adipocyte, the cellular basis of obesity. Now, as adipocytes increase in size and number, they secrete the adipokines and like leptin that signal the hypothalamus to regulate hunger and even energy balance. So, however, in obesity, a leptin resistance impairs the brain's ability to regulate that energy balance, and that is what is contributing to the development of obesity. Now, leptin is a hormone secreted by those fat cells that signals that they're full to the hypothalamus in the brain. And in obesity, despite the high leptin levels, the brain becomes resistant to the leptin's effect. And this leptin resistant prevents the hypothalamus from actually properly detecting energy surplus and responding by reducing appetite and increasing that energy expenditure. As a result, that overconsumption continues and unabated while energy expenditure remains low. perpetuating a positive energy balance that drives further weight gain and leads to the obesity. Now, with obesity, the excess of visceral fat accumulation or visceral adipose fat contributes to insulin resistance and that type 2 diabetes through several different mechanisms. So, one, that visceral adipocytes secrete increased amounts of pro inflammatory adipokines like leptin and resistant, and cytokines. So, that TNFA or TNF alpha and IL interleukin 6. That's what disrupts the insulin signaling pathways in the liver and even in the muscle cells. Now, there's a reduced secretion of the insulin sensitizing hormone, um, adiponectin, from dysfunctional visceral fat deposits. And then we see the chronic low grade inflammation from visceral fat macrophage that infiltrates into and induces the oxidative stress. Um, so, and that is impairing that insulin action as well. We have the excess fatty or free fatty acid released from lipolysis in visceral fat, which worsens lipotoxicity and insulin resistance in the liver and muscle. And then finally, we have the visceral fat accumulation, which is associated with ectopic fat deposits in the liver and muscle, further exacerbating the insulin resistance. The combination of all of these factors stemming from that dysfunctional visceral adipose, which creates that vicious cycle that perpetuates and worsens systemic insulin resistance, which is that key driver to type 2 diabetes in that pathogenesis. Now, when we think about in obesity, remember, excess fat tissue becomes inflamed and releases that inflammatory substances. These inflammatory substances are chronic inflammation, which interfere with the insulin's ability to regulate blood sugar levels properly. So, as a result, the body becomes resistant to insulin effects and causes insulin resistance and ultimately to an increased risk of that type 2 diabetes. All right, these are a few visuals that I found helpful, especially whenever you're trying to compare and contrast the two that we're going to go into, the hyper and hypothyroidism. It's a great way to learn and study, which is to create either a guide or a concept map or a chart somehow, whatever works best for you. Some people do literally a drawing like this to kind of compare and contrast, and that helps them remember. So that way they can process the information, remember the information, and apply it to the information or quiz questions or just scenarios that we're looking at. All right, let's dive into this. So, hypothyroidism versus hyperthyroidism. Now, remember, you've got the supplemental PowerPoints, which include those great visuals as well, to help you with the learning process. Now, I am starting with hypothyroidism, which first we have a figure 2210 from the textbook. And with hypothyroidism, there's a limited production of thyroid hormone by the thyroid gland. And it is more common in our women and the elderly that we see this. It's not that it's not in men, but it's just more common in women and then the elderly. Hypothyroidism can be a primary or a secondary or a subclinical hypothyroidism. So that's what we're going to dive into, is looking a little bit closer at those three types. So in primary, that is the loss of thyroid function that leads to that decreased production of thyroid hormone. And one of the most common causes of primary hypothyroidism is more common in women than in men, and mostly caused by an autoimmune thyroiditis disease called Hashimoto's. And it's more common in women than in men. So that way, when we see this, that is something to consider if you're looking at hypothyroidism in a woman versus a man, is considering that primary cause of Hashimoto's. Other causes include loss of thyroid tissue due to like a surgery or radioactive treatment for hyperthyroidism. Sometimes that head and neck radiation, certain medications can attack, and even that endemic iodine deficiency. Your causes on the primary iodine deficiency, we have that endemic goiter in the US due to the use of iodized table salt and fortified foods. So that is something to think about. Now, primary is the most common, but we do see secondary, which is central, and it is less common, but typically related either to a pituitary or a hypothalamic failure. The cause is due to the pituitary's failure to synthesize adequate amounts of TSH or a lack of TRH, which pituitary tumors compress surrounding pituitary cells or consequences of their treatment are the most common causes. So, other causes include like TBI, subarachnoid hemorrhage, and even a pituitary infarction. Sub Subclinical hypothyroidism is mild and is an elevation in that TSH level with normal levels of circulating thyroid hormone. Now, the clinical manifestations in table 22.3 of hypothyroidism affects all of the body systems over months or years. So, symptoms are related to the level of thyroid hormone deficiency and lowers the energy metabolism and heat production. You have that low basal metabolic rate, which produces that cold intolerance, lethargy, tiredness, and even a slightly lowered basal body temperature, and may actually have diastolic hypertension as well. Even constipation, other manifestations you may see with hypothyroidism. If we look at the body system, so neurologic, you can sometimes have confusion, syncope, slowed speech and thinking, memory loss, headaches, slow and even clumsy movements, reproductive issues that decrease libido, higher incidence of spontaneous abortion. And in men, we might see erectile dysfunction. Hematological, we see decreased in red cell mass, leading to that normocytic or normochromic anemia. Microcytic anemia is associated with vitamin B12 deficiencies. And then in cardiovascular, we see reduction, stroke volume, and heart rate causing that lowered cardiac output. So you see bradycardia, and that's where that cool skin and cold intolerance. And then sometimes we even see an enlarged heart. Pulmonary, they might have symptoms of dyspnea. Renal, we see the reduced renal blood flow and glomerular filtration rate, leading to that decreased renal excretion of water. So we have the increased total body water and dilution of hyponatremia, reduced production of erythropoietin. GI, we see a lot of constipation, weight gain, fluid retention, decreased absorption of most nutrients, and even protein metabolism. You have that decreased glucose absorption and delayed glucose uptake, and that elevated serum level lipid values. Now, musculoskeletal, we see muscle aching, stiffness, slow movement, and even slow tendon jerk reflexes when you're doing that assessment. Stiffness in the joints and achingness in the joints as well. And finally, in the skin or in tegumentary, you see the dry, flaky skin, the dry, brittle head and body hair, reduced growth of nails and hair, slow wound healing, cool skin, which decreases that circulation to skin as well. So, one of the signs that we have to watch for in hypothyroidism, which can be very severe and longstanding, is that myxedema. So this results from altered composition of the dermis and other tissues. Myxedema coma is something that is a medical emergency, and it's associated with severe hypothyroidism. It's precipitated usually by infections or a discontinuation of thyroid supplements, overuse of narcotics or sedatives. So that is something to think about in our patients. We have to watch for, or it occurs because of an acute illness. Signs and symptoms we see is that hypothermia with the shivering, hypoventilation, hypotension, hypoglycemia, lactic acidosis, and then coma. Treatment, we talked about for primary hypothyroidism, that diagnosis is made from clinical symptoms. Um, in the measurement of TSH, where we see it's increased and decreased thyroid hormone. So that total T3, both total and free T4. And it's typically that hormone replacement. So we see the medications like levothyroxine, Synthroid, and other hormone replacements. Now, then we go into hyperthyroidism or thyrotoxosis. So this is a form of thyrotoxosis in which excess amounts of thyroid hormone are secreted from the thyroid gland. And thyroid hormone, or TH, are regulated by a negative feedback loop involving the hypothalamus, the pituitary gland, and the thyroid gland. Now we have primary hyperthyroidism, which includes like your disease process, like your Graves' disease. We see toxic multinodular goiters, a solitary toxic adenoma, and rarely we see follicular thyroid carcinoma. There's also central or secondary hyperthyroidism, which is a little bit less common, but it's caused by TSH secreting pituitary adenomas as well. Now, these manifestations, again, we're going to look at table 22.2 in the textbook, which shows that increased metabolic rate with a heat intolerance and increased tissue sensitivity to stimulation by the sympathetic division of the autonomic nervous system. You have other systems. If you look at the body systems, starting with the endocrine, we see enlarged thyroid gland or a goiter, systolic or continuous bruit over the thyroid. Hypercalcemia is a concern. Reproductive, in men, we have the erectile dysfunction, and in both, we see decreased libido sometimes. GI, they not always, but a weight loss, increased peristalsis leading to less formed or more frequent stools versus we think about that hypothyroidism where they were having constipation. GI symptoms also can include that nausea, vomiting, anorexia, abdominal pain. And then in their skin, we see excessive sweating, flushing, and even warm skin or heat intolerance. Their hair is fine, soft, and straight. Temporary, goodness, hair loss, nails that grow away from the nail beds. And then in sensory, we look at the ocular manifestations, including that elevated upper eyelid leading to the decreased blinking and a staring quality. Or even a fine tremor of the lid. Now, in Graves' disease, which is an autoimmune disorder, the body produces antibodies called thyroid stimulating immunoglobulins, and that's TSIs. And these bind to and overstimulate the thyroid glands or the TSH receptors. This leads to excessive production and secretion of that thyroid hormone, the T3 and T4. That's what results in a state of hyperthyroidism or thyrotoxosis. Now, the key pathophysiology events here are that autoimmune reaction produces that TSI antibodies that mimic the TSH. The second one is the TSIs bind to and continuously stimulate that thyroid follicular cells. The third is that overstimulation of the thyroid gland, which enlarges and forming that goiter. And lastly, that excessive thyroid hormone secretion causes symptoms like that weight loss, heat intolerance, tachycardia, tremors, and even that increased metabolism. Now, in some cases, the TSIs also stimulate orbital tissues and that skin, and that can cause ophthalmopathy, which is that eye protrusion or swelling, or tibial myxedema, which is that skin lesions on the shins. Graves' disease, that dermopathy, and the pretibial myxedema refers to skin manifestations that can occur. So it's characterized by that non-pitting edema and thickened, indurated skin lesions, most commonly seen on the shins or the dorsum of the feet. There are two different categories when we think of Graves' disease for the that are very distinguishable in the clinical manifestations of Graves' disease. So on the ophthalmopathy associated with Graves' disease, we see It's resulting from the hyperactivity of the autonomic nervous system. So that first being the lag of the globe on the upward gaze, or a lag of the upper lid on the downward gaze. And then the second is the infiltrative changes with the enlargement of the ocular muscles. More than half the population diagnosed with Graves' disease are affected by these changes. So there are some examples here in the textbook, but I have one listed or look here on the slide, which is very apparent. You can see the downward gaze as well. And that in Graves' disease, it's an abnormal buildup and accumulation of connective tissue and inflammation and swelling within the room behind the eye. And this buildup puts the pressure of the eyeball itself, causing it to bulge outward from the socket. And that's the condition called proptosis. And that's the swelling around the eye that also leads to the periorbital edema or puffiness around the eyes. Additionally, that accumulated tissues and inflammation can affect the muscles that control the eye movement. So this results in weakness of the extraocular muscles, and that can impair the ability to coordinate the movement of the eyes together. So consequently, the eyes become misaligned, and this can lead to double vision or diplopia. In essence, the overcrowding and inflammatory changes within the confined orbital space push the eye forward and impair its movement. Now, if we think about another disease process, is Addison's disease. So looking at it really quickly, it's characterized by the elevated ACTH levels and inadequate corticosteroid synthesis and mineral corticoids. Addison's disease, or primary adrenal insufficiency, is caused by dysfunction or destruction of the adrenal cortex, and that leads to the deficient production of that glucocorticoids or cortisol and aldosterone. Now, some key characteristics include fatigue, muscle weakness, weight loss, hyperpigmentation of skin, and even salt cravings, hypotension, and electrolyte imbalances like hyperkalemia and hyponatremia. Now, you might see, or patients might complain of nausea, vomiting, abdominal pain, some diarrhea sometimes, and an acute adrenal crisis, that severe dehydration, hypoglycemia, hypotension, and that progresses to the vascular collapse and shock, which is a medical emergency. Now, chronic cortisol deficiency also causes lymphocytosis. Prompt glucocorticoid and mineral corticoid replacement is essential whenever we look at managing the crisis or acute crisis and preventing that life-threatening complication. Let's see. Sorry, I think I had an image here on Graves. Okay. Lastly, we're going to look at the pathophysiology of polycystic ovary syndrome, or PCOS. And this involves the hyperandrogenic state of elevated testosterone levels from the ovaries and adrenal glands. So now this leads to clinical manifestations of that excessive male hair growth in women, typically involving the face, chest, abdominal, and or back, acne, and even some male pattern baldness. PCOS is also characterized by insulin resistance and compensatory hyperinsulinemia, which further exacerbates that androgen excess. The typical hormone profile shows an elevated LH-FSH ratio due to the inappropriate secretion of the gonadotropin. Now, the increased LH stimulates the ovarian androgen production, while relatively low FSH impairs that follicular matrician, leading to anovulation and that formation of polycystic ovaries. Now, this is a vicious cycle. So when we think about this, we look at we think about anovulation, or the lack of ovulation, is one of the primary causes of irregular menstrual cycles. When ovulation doesn't occur, the normal cyclic hormonal changes that regulate the menstrual cycle are disrupted. So that's what leads to the irregularities in the timing and the flow of the menstrual bleeding. Um, and this is the inability to regularly ovulate, which is a major cause of infertility in the women with PCOS. The hormonal imbalances in PCOS, particularly the elevated androgen levels and disrupted gonadotropin secretion, impair normal ovulation. So without ovulation, there is no egg released for fertilization, making it very difficult to conceive naturally. Now, restoring more regulatory or regular ovulatory cycles throughout lifestyle changes or even medications is often the key part of improving fertility in our PCOS patients, especially those that are seeking to get pregnant. I know that was a lot of information, and I know there's quite a few chapters that we are looking at this week. So we did just cover some of them. So the disease processes that we're looking at, make sure that if you guys have any questions or concerns, please reach out via email. When doing so, make sure that you are utilizing the inbox within the Canvas course. That is easier for me to check. Sometimes it's very easy to miss if it's sent through Outlook. So I do apologize. I do look at the Outlook email, but the inbox I try and look at least once or twice a day. So this does conclude our week 3 content session. I hope you all have a wonderful week. Thank you.